Ever felt that sudden flutter in your chest? Like a racing sensation that just seems to come out of nowhere.
Yeah, or you see those squiggly lines on medical shows, right?
Exactly. And you wonder what they actually mean. Ever wish you could understand what might be happening with your heart without, needing years of med school?
He agrees.
If any of that sounds familiar, you are absolutely in the right place.
Welcome.
Welcome to the Deep Dive. We're your shortcut to making sense of complex topics. You, the learner, want to grasp this stuff quickly, thoroughly, but without feeling totally overwhelmed by jargon.
Right, our mission here is to pull out the most important bits, the really fascinating nuggets for you.
So, what are we actually going to unpack in this deep dive?
Well, we'll look at what narrow QRS tachycardia actually is.
The different types, yeah.
The different forms it takes, the electrical stuff happening underneath.
The mechanisms, yeah. And how they might show up on an ECG, that electrocardiogram.
Exactly, the clues in those squiggly lines.
Before we jump in, though, a huge thank you to London Heartbeat Academy UK. Their educational support has been fantastic.
Absolutely, and if you're keen to learn more, they have, over 150 popular courses? Definitely worth checking out.
For sure. And hey, make sure you subscribe to London Heartbeat Academy's social media. They're on Facebook, Instagram, YouTube. You get free regular updates, and you won't miss out on their future amazing discussions.
Good stuff. Okay, ready to plunge in?
Let's do it. Our deep dive on narrow QRS tachycardia starts now.
Okay, so let's start with the absolute basics. Tachycardia.
Fast heart rate.
Basically, yeah.
Yeah.
Just means the heart's beating too fast. Now, when we talk specifically about sinus tachycardia...
That means it's still coming from the normal pacemaker.
Exactly. The electrical impulses are still starting in the sinoatrial node, the SA node, the heart's natural pacemaker, but it's firing off faster than 100 beats per minute. And the interesting thing about sinus tachycardia is that it often starts gradually and ends gradually. Not like some others that can just switch on and off.
Right, like flipping a switch. So if someone's heart is racing, how do we actually tell if it's sinus tachycardia just from looking at an ECG? What are the telltale signs on that recording?
Good question. Crucial, really. The P waves are key.
The little bumps before the big spike.
Those are the ones representing atrial contraction. In sinus tachycardia, you will see P waves, and like we said, the rate's over 100.
Okay.
And importantly, each QRS complex, that bigger spike showing the ventricles contracting, should be preceded by one of these P waves.
Like every ventricular beat gets a heads up from the atria.
Pretty much. And the PR interval, that time it takes for the signal to get from the atria to the ventricles, that's to be longer than 0.12 seconds.
Okay, so P waves leading the charge right before each QRS and a decent PR interval. Anything else on the ECG that really screams sinus tach?
Yes, absolutely. The shape of the P wave, its morphology, is very telling.
How it looks.
Exactly. In sinus tachycardia, these key waves should normally be upright, pointing upwards in certain leads. Lead I, lead 2, AVF, and also in V3 through V6.
Okay.
Now, here's the interesting bit. If you see a P wave that isn't upright in those specific leads, yeah, it's a strong sign that the impulse probably isn't starting in the SA node. It's likely coming from somewhere else, an ectopic origin.
That makes a lot of sense. So just because the heart's racing doesn't automatically mean it's the sinus node doing it. Could be other things going on.
Precisely.
So what kind of things can make the SA node suddenly speed up like that?
There's quite a range of triggers, actually. We can group them into physiological and pathological causes.
Okay, physiological first, the normal stuff.
Right. These are basically the body's normal responses. Think exercise, feeling really scared, strong emotions, anxiety.
Yeah.
Your heart naturally speeds up.
Makes sense. Fight or flight kicking in.
Exactly. And it's also totally normal for newborns to have a faster resting heart rate.
Right, so in those cases, the body's just doing its thing. But what about the pathological causes? When is a fast heart rate a sign that something might be wrong internally?
Pathological causes point to underlying medical conditions. Could be serious things like an acute pulmonary embolism, a blood clot in the lungs.
Scary.
Very. Or acute pulmonary edema fluid buildup in the lungs. Also, certain conditions like thyrotoxicosis, an overactive thyroid,
Okay.
sepsis, which is a severe infection response, even things like pain, anemia, low red blood cells, low blood pressure, shock, major blood loss.
Wow.
And we can't forget drugs. Certain medications like atropine, hydralazine, epinephrine, norepinephrine, adrenaline, even amyl nitrite can speed the heart up.
That's a seriously long list of potential triggers. So what's actually going on electrically inside the heart? What's the mechanism making the SA node go into overdrive in these situations?
It often boils down to an imbalance in the autonomic nervous system.
The body's automatic control system.
Exactly. The one that handles heart rate, breathing, all that stuff without thinking about it.
Yeah.
So you might get increased sympathetic stimulation. That's the fight or flight system again.
Yeah.
Or decreased parasympathetic activity,
Mm-hmm.
which normally slows the heart down.
Okay, so the controls are a bit out of whack. You mentioned the SA node is in a specific spot. Where is that exactly, and how does the signal normally spread out?
Right. It sits in the right atrium, one of the upper chambers, kind of on the back and right border.
Okay.
And normally the impulse spreads across from the right atrium to the left atrium and also goes from top to bottom through the atria, directionally, usually somewhere between 0 and 90 degrees on the electrical axis.
And does that spread pattern ever change, like when the heart speeds up or slows down?
Yeah, interestingly, it can shift slightly.
Yeah.
Within the SA node itself, the main pacemaker cells can move a bit.
Really?
At faster rates, they tend to shift upwards more cranially. This can make the P wave axis a bit more vertical, closer to that 90 degrees.
And slower rates?
They tend to shift downwards, more caudally, resulting in a more horizontal axis, closer to 0 degrees. It's a subtle thing, but it happens.
Huh. That's a fascinating little detail. The heart's electrical map isn't totally fixed. Okay, let's switch gears slightly. You mentioned another type earlier, postural orthostatic tachycardia syndrome, or POTS. The name suggests it's linked to standing up, right?
Exactly right. POTS is all about that rapid increase in heart rate, specifically triggered by getting upright, like standing up.
And it goes away when you lie down?
Usually, yes. Lying down relieves it.
So it's not just a fast heart rate all the time, it's tied to posture. What could cause that kind of reaction?
It can be varied.
Yeah.
Sometimes it might be a primary issue with the sinus node cells themselves. They're just overly sensitive to posture change.
Okay.
But more often, it seems to be secondary to other factors, things like a viral infection that happened before the POTS started, or damage to the autonomic nerves, autonomic neuropathy. Could also be too much blood pooling in the legs and abdomen when standing, low overall blood volume, or maybe the blood vessels in the periphery aren't constricting properly when you stand up.
So it could be the pacemaker, the nervous system control, blood volume, vessel tone, lots of possibilities.
Yeah.
How do doctors actually pin down a POTS diagnosis?
A key test is the tilt table test.
Where they strap you to a table and tilt you up?
Pretty much, yeah. Securely strapped, then move from lying flat to upright. What suggests POTS is a heart rate jump of 30 beats per minute or more from baseline, or the rate going up to 120 or higher,
Okay.
within the first 3 minutes of being upright. And crucially, this happens without a big drop in blood pressure.
Right.
No significant drop like 30 millimeter Hg systolic or 20 millimeter Hg mean pressure.
Okay, so the heart races to compensate, but the blood pressure doesn't actually plummet, like in some other conditions. Makes sense. Now, there was also inappropriate sinus tachycardia. Sounds like the heart's overreacting for no good reason.
That's a good way to put it. Inappropriate sinus tachycardia, or IST, is tricky because you've got this persistently high resting heart rate or a really exaggerated rate increase with minimal effort.
Right.
But you can't find a clear underlying medical condition or physiological reason to explain it. Unlike regular sinus tach, where you can often point to a cause like exercise or fever, with IST, it's like, why is it beating so fast? There's no obvious trigger.
That must be really frustrating for the person experiencing it and for the doctors. So if there's no clear cause, what are the theories? Why might it happen?
Well, there are kind of two main lines of thought. One is enhanced automaticity within the sinus node itself.
The pacemaker cells are just intrinsically too eager.
Exactly, an intrinsic issue. The other possibility is dysautonomia, or neurohormonal dysregulation.
So a problem with the broader nervous system control are hormone signals.
Right, an extrinsic cause.
Right.
The SA node might just be reacting inappropriately to signals it's getting. Interestingly, IST seems to pop up more often in young women, particularly those in healthcare, maybe in their 30s.
Huh. Specific demographic. So what are the main symptoms? How does it show up in daily life?
The big thing is that inappropriately high heart rate, even when just resting or doing very little.
Just sitting there, heart's racing.
Pretty much. And then when they do exercise, the rate jumps up way more than you expect for the effort involved. People often report palpitations, feeling their heartbeat, maybe some chest discomfort, shortness of breath, dizziness, fatigue, even with minor activity.
Okay, so we've covered sinus tach and its variations. Let's broaden out now to supraventricular tachycardia, SVT. The name itself, supraventricular, suggests it starts above the ventricles, right?
Precisely. Supraventricular tachycardia is basically a catch-all term for any fast heart rhythm that originates above the ventricles.
So in the atria, the top chamber.
Yes, or in the AV junction, that area connecting the atria and ventricles, which includes the AV node and the bundle of His. Anywhere above where the main electrical highway splits to go to the two ventricles.
And how does starting up there, above the ventricles, affect what we see on the ECG, particularly the QRS complex width?
Good question. Because SVTs start above that crucial split point, the bifurcation of the bundle of His. The signal usually travels down the normal electrical pathways to activate the ventricles.
The usual route.
Right. And this leads to synchronized, coordinated contraction of the ventricles. On the ECG, this shows up as narrow QRS complexes, typically less than 120 milliseconds wide.
So narrow QRS usually means the problem starts higher up?
Generally, yes. It's a key differentiator from ventricular tachycardias, which start in the ventricles and cause slower, less coordinated activation, leading to those wide QRS complexes.
Got it. Now, you mentioned two main buckets for SVT, reentry SVTs, and those from enhanced automaticity. Let's tackle reentry first. What's a reentry circuit? Sounds like an electrical loop.
That's a perfect way to think about it. A reentry circuit is an abnormal electrical pathway where an impulse, instead of just activating the tissue and stopping, gets caught in a self-sustaining loop.
Going round and round.
Exactly. It just keeps circulating, reactivating the heart muscle over and over again, causing that rapid heart rate. Several SVTs are caused by these loops. Think of it like an electrical racetrack where the signal never finishes the lap properly.
Okay, cool analogy. So what are the main types of these reentry SVTs?
The big ones are atrioventricular nodal reentrant tachycardia, AVNRT, where the loop is right around the AV node itself.
Okay.
Then there's atrioventricular reentrant tachycardia, AVRT, which involves an extra connection, a bypass tract, between the atrium and ventricle.
An extra wire, basically.
Kind of, yeah. We also have rarer ones, sinoatrial reentrant tachycardia, SART, involving the sinus node area, and intraatrial reentrant tachycardia, IRT, where the loop is stuck within one of the atria.
Let's start with the most common, AVNRT, the loop around the AV node. How does that short circuit get going?
So in AVNRT, you usually have this tiny reentry circuit, a micro reentry circuit, within or right next to the AV node. It typically uses two slightly different electrical pathways that naturally exist there.
Two paths in the same area.
Yeah, one conducts signals relatively slowly, the slow pathway, and another conducts them faster, the fast pathway. And AVNRT is super common, accounts for over 60% of SVTs.
Wow, the majority. Who usually gets AVNRT? Is there a typical profile?
Often seen in young females or just generally healthy people. A key feature is the abrupt onset and termination. It starts suddenly, stops suddenly, like flipping that switch we mentioned.
Right, the light switch tachycardia. So, can you explain a bit more how these slow and fast pathways interact to cause this loop?
Sure. The slow pathway has a shorter refractory period. That means it recovers quickly after carrying a signal and is ready to go again sooner.
Okay.
It usually conducts signals anterograde from the atria down towards the ventricles. The fast pathway has a longer refractory period, takes longer to recover, and typically conducts retrograde back up towards the atria.
So normally they work together, but in AVNRT something goes wrong.
Exactly. Often a premature beat for the atrium kicks it off. This early beat arrives at the AV node when the fast pathway is maybe still refractory, still recovering.
So it can't go down the fast lane.
Right. But the slow pathway has recovered, so the impulse goes down that way instead, because it's slower by the time the signal gets to the bottom.
The fast pathway has recovered.
You got it. The fast pathway is now ready, and the impulse can zip back up retrogradely to the atria, completing the loop.
And then it just keeps going, down slow, up fast.
Down slow, up fast, round and round. The ventricles get activated normally via the slow pathway going down, so the QRS is narrow. But the atria get activated backwards from bottom to top via the fast pathway coming up.
Which causes those inverted P waves you mentioned.
Precisely. Inverted P waves, especially in leads 2, 3, and AVF, because the activation is going upwards.
Okay, so that's the mechanism. What does typical AVNRT look like on the ECG?
In typical AVNRT, that's about 90% of cases. You'll see a very regular, fast rhythm, usually over 90 BPM. But here's the thing. In maybe 2/3 of cases, you might not even see the P waves clearly. Because the atria activated retrogradely up the fast path, and the ventricles activated anterogradely down the slow path get stimulated almost simultaneously. So the retrograde P wave gets buried inside the much larger QRS complex.
Hidden. Sneaky.
Can be. If you do see P waves, they'll be retrograde inverted in 2.3 AVF, and because they happen so close to the QRS, they can sometimes distort the end of it, looking like a little dip called a pseudo-S wave, or maybe even a little blip called a pseudo-R wave in lead V1.
Wow, subtle clues. Sounds tricky. You said typical AVNRT. Is there an atypical one too?
Yep, there is. Atypical AVNRT. It's basically the reverse circuit.
So down the fast pathway and up the slow one.
Exactly. Anterograde down the fast, retrograde up the slow. We call it fast-slow conduction.
And how does that flip change the ECG? What are we looking for?
In atypical AVNRT, you see retrograde P waves, but they happen before the next QRS complex.
Okay, so P wave, then QRS, but the P wave is inverted.
Right. And this means the RP interval, the time from the QRS peak to the next P wave peak, is longer than the PR interval would be. That relationship flips compared to typical AVNRT.
Longer RP than PR. That's the key for atypical.
It's a major clue, yes. The notes even show an ECG example. You can clearly see inverted Ps popping up before the QRS in 2, 3, and AVF. Though they do caution that this pattern could also be seen in other SVTs like focal atrial or junctional tachycardia, so context is everything.
Right. The timing of that P wave relative to the QRS is super important for figuring out the type of SVT. Okay, let's move to the second most common reentry type, AVRT, atrioventricular reentrant tachycardia. This one involves that bypass tract, right? The extra wire.
Exactly. AVRT requires an accessory pathway, that extra electrical connection directly linking the atrium and ventricle, bypassing the AV node.
So it creates another route for the signal.
Yeah, setting the stage for a potential reentry loop. It's the #2 cause of SVT, about 30% of cases.
How does having this extra pathway actually cause the fast rhythm?
Well, now you have two ways for the signal to get between the atria and ventricles. The normal AV node path and the accessory path. A premature beat might find one path blocked, still refractory, but the other open.
Goes down the open path.
Right. And by the time it gets to the other end, if the first path is recovered,
It can go back up the other way, completing the loop.
bingo, you've got your reentrant circuit going.
Okay. The notes mention two main forms, orthodromic and antidromic. Sounds like opposite directions again. What's the difference?
It's all about which way the signal goes down and which way it comes back up.
Orthodromic is the common one.
Okay,
In orthodromic AVRT, the signal goes down through the normal AV node pathway.
the usual route down.
Right. And then it comes back up to the atria via the accessory bypass tract.
The back road up.
Exactly. Since the ventricles are activated normally via the AV node, the QRS complex is narrow.
Makes sense.
But because the atria are activated retrogradely via the bypass tract, you see retrograde P waves, usually right after the QRS. Inverted in 2, 3 AVF again. So narrow QRS, then an inverted P wave close behind.
Yep. We call this slow-fast activation, slow down the AV node, fast up the bypass, and it results in a short RP interval. The P wave is closer to the QRS that came before it than the one that comes after.
Okay, orthodromic, down normal, up bypass, narrow QRS, short RP. Now what about antidromic, reverse route?
You got it. Antidromic AVRT flips it. The signal goes down the accessory bypass tract.
Moves the AV node going down?
Right, and then it returns back up to the atria via the normal AV node pathway.
Okay, so down the bypass, up the normal route. How does that look?
Well, since the ventricles are activated directly via the fast bypass tract without the AV node delay.
The QRS will be wide.
Exactly. Wide QRS complex, usually over 0.12 seconds. And the retrograde P waves, representing atrial activation back up the AV node, appear before the next QRS complex, again, inverted in 2, 3 AVF.
So wide QRS, and the P wave comes before it.
Correct. This is fast, slow activation, fast down the bypass, slower up the AV node, and it results in a long RP interval. The P wave is further away from the preceding QRS.
Wow. So QRS width is a huge clue. Narrow for ortho, wide for anti, and the P wave timing flips too. The notes also mention something called PJRT, permanent junctional reciprocating tachycardia. Is that related?
Yeah, PJRT is basically a rare, often incessant form of orthodromic AVRT.
Incessant meaning it's there almost all the time.
Pretty much, yeah. Often more than 12 hours a day. It can happen spontaneously or be triggered by exertion.
Yeah.
Because it's so persistent, it can actually weaken the heart muscle over time, tachycardia-mediated cardiomyopathy.
That's serious.
You can be. On the ECG, it looked like orthodromic AVRT key waves after the QRS, short RP, inverted in the inferior leads. But the bypass tract involved in PJRT often has unique properties like very slow conduction, which contributes to its incessant nature. It's usually located in the post-receptal area near the coronary sinus opening.
Interesting how the specific properties of the bypass tract matter so much. The notes even say the location of the bypass tract, left versus right side, can change how the P wave looks in lead eye.
Absolutely. If the pathway is on the left side, atrial activation goes left to right, often giving inverted P waves in lead eye.
And right-sided?
Right to left activation, so P waves in lead eye are more likely upright. Most pathways are actually found in the left ventricular free wall, then postseptal, then right free wall, then anteroseptal.
Fascinating.
And it gets even more complex. Things like bundle branch blocks happening during the tachycardia can interact with the circuit. A left bundle branch block might not change the rate much, but a right bundle branch block, if the bypass tract is also on the right,
Might slow things down.
could do, yeah.
Yeah.
Because the impulse has to take a longer detour via the left bundle to get to the right ventricle and then up the bypass tract.
Oh.
Makes the whole circuit longer, so the rate slows.
Man, the heart's electrical system is just incredibly intricate. Okay, we've hit AVNRT and AVRT hard. Let's touch on the rarer reentry types. SART and IART, sinoatrial reentrant tachycardia SART, involves the sinus node area. How does a loop form there?
Yeah, SART uses a small localized reentry circuit that actually includes the sinus node itself and the atrial tissue right around it.
Okay.
It causes episodes of fast heart rate, again with that sudden start and sudden stop, often kicked off or stopped by a premature atrial beat.
And the ECG?
On the ECG, you see P waves before each QRS, and crucially, these P waves look identical to the person's normal sinus P waves, upright in AVF, just like normal.
So it looks like sinus tatch.
It can, but the rate is usually a bit slower, maybe 120, 150 BPM, and the key is that abrupt start-stop, which points towards re-entry rather than a gradual sinus response.
Got it. Looks normal, just faster, but flips on and off. Now, intraatrial reentrant tachycardia, IR8. Where's this loop?
IART involves a re-entry circuit confined entirely within a specific area of one of the atria, right or left.
Not involving the nodes.
Nope. Often related to structural changes in the atrium scar tissue from old heart attacks, surgeries, inflammation, maybe previous ablation procedures.
So the scar tissue creates the pathway for the loop.
Often, yes. The impulse just travels in a circle within that altered atrial area. On the ECG, you see uniform P waves before each QRS, rate usually 110, 200 BPM. PR interval is typically normal, over 0.12 seconds.
And the P waves.
Their shape can vary a lot depending on where the circuit is. Could be upright, biphasic, or inverted in TIAN3 AVF. A clue for IART is often that the PR interval is shorter than the RP interval.
Okay, a localized loop within the atrium itself, often due to scarring, with consistent P waves whose shape depends on location. Right, we've covered the reentry stuff. Let's switch to the other big category, SVTs caused by enhanced automaticity. What's the basic idea here?
These tachycardias happen because of repetitive rapid firing from an ectopic focus.
Ectopic meaning out of place.
Exactly. A cell or group of cells outside the normal SA node pacemaker just starts firing off electrical impulses really fast on its own initiative, like a rogue pacemaker.
Okay, so rogue cells firing too fast. What are the main SVTs in this category?
The big ones we'll talk about are focal atrial tachycardia, multifocal atrial tachycardia, and junctional tachycardia.
Let's start with focal atrial tachycardia. Sounds like it comes from one specific spot in the atrium.
Precisely. Originates from a single, localized focus in either the right or left atrium. The impulse then spreads outwards from that one point.
And what makes that spot start firing so fast?
Well, there are three main mechanisms proposed. One is enhanced automaticity itself. The cells just start firing faster intrinsically. That's automatic atrial tachycardia.
Okay.
Second is intraatrial micro-reentry. Similar to IART, but a really tiny loop right at that focus.
No, a mini reentry.
Kind of. And third is triggered automaticity, which can sometimes show up as atrial tachycardia with a 2.1 AV block, where only every other beat gets through to the ventricles.
And what conditions or substances might trigger this focal firing?
Things like acute myocarditis, heart muscle inflammation,
Right.
chronic cardiomyopathy, atrial tumors, certain drugs like dobutamine, other catecholamines, theophylline, even caffeine and nicotine. Electrolyte imbalances can also play a role.
What does focal atrial tach look like on the ECG? What are the key features?
You'll see P waves before the QRSs, but they'll look different from the person's normal sinus P waves because they're ectopic, right?
Right. Different origin, different shape.
Exactly. But importantly, all the P waves during that episode will look the same because they're all coming from that single focus. The PR interval is usually normal, 0.12 seconds or more. Atrial rate can be quite fast, maybe around 250 BPM.
Okay.
Sometimes you might see AV block, where not every P wave leads to a QRS because the AV node might not be able to keep up with the rapid atrial rate. When that happens, the baseline between the P waves is usually flat, isoelectric.
Unlike atrial flutter with its wavy baseline.
Exactly. And focal atrial tach usually stops with the QRS complex, not a P wave like some reentry rhythms.
So key is P waves that look different from sinus but are consistent within the episode, and a normal PR usually. The notes also mention that the location of the focus can sometimes be guessed from the ECG. That sounds detailed.
It is pretty cool. Most focal ATs, maybe 75%, are in the right atrium. Places like the crista terminalis, tricuspid annulus, near the coronary sinus or AV node are common hotspots.
And the left atrium.
About 25%, often near the pulmonary veins, mitral annulus, or atrial appendages. And yeah, the ECG gives clues. For instance, a right atrial origin might give inverted or biphasic P waves in V1, maybe upright in AVL.
And left atrial.
Might be positive or biphasic Ps in V1, often flat or inverted in AVL. Superior origins tend to give upright Ps in the inferior leads to A3 AVF and inverted in AVL. Inferior origins might give inverted Ps in inferior leads, upright in V1, and a long RP interval.
That's amazing, pinpointing the source from the surface ECG. Multifocal atrial tachycardia, MAT. Name suggests multiple sources.
Exactly. MA means you've got atrial impulses firing off from at least 3 different ectopic foci within the atria.
3 or more rogue pacemakers all going at once.
Pretty much, yeah. Chaos.
Who tends to get MA?
Any common associations?
It's most often seen in elderly patients, especially those with acute flare-ups of COPD.
Lung disease.
Right. Also linked with pulmonary hypertension, coronary artery disease, electrolyte problems, lung infections, and certain drugs like theophylline or beta agonists. It usually means the person is quite sick with significant underlying issues.
So, often a sign of serious underlying stress. What are the ECG hallmarks for MAT?
The absolute key is seeing at least 3 consecutive P waves that have distinctly different shapes, different morphologies.
Showing those different origins.
Exactly. Plus, the atrial rate is over 100 BPM, and the rhythm is irregular. Both the PR intervals and the RR intervals will vary. And again, usually an isoelectric baseline between the P waves.
Okay.
If you see that pattern, multiple P wave shapes, irregular rhythm, but the heart rate is below 100, we actually call it chaotic atrial rhythm instead of MAT.
Ah, okay. Rate matters for the name. Got it. 3 different Ps, irregular, rate over 100 for MAT. Let's turn to junctional tachycardia now. Where does this one start?
Junctional tachycardia comes from the AV junction, that middle ground, including the AV node and the bundle of His between the atria and ventricles. Okay, the connection point. What are the typical ECG findings?
Well, the P waves are variable. Since the impulse starts in the middle, it can go down to the ventricles and also back up to the atria retrograde.
So you might see inverted P waves again?
You might. If the retrograde activation happens at the same time as ventricular activation, the P wave gets buried in the QRS, so you don't see it.
Hidden again.
Yep. If you do see retrograde P waves, they'll be inverted in 2, 3 AVF, and often look narrower than sinus P waves. Their timing is key too.
How so?
If the retrograde P happens just before the QRS, you get a short PR interval, less than 0.12 sec. If it happens after the QRS, you get a short RP interval, usually 0.20 sec or less.
Okay.
Sometimes in junctional tach, the atria and ventricles beat completely independently AV dissociation. And interestingly, if someone's in atrial fibrillation, a junctional rhythm can sometimes take over and make the ventricular rhythm look regular, which can be misleading.
The notes distinguish between non-paroxysmal and paroxysmal junctional tachycardia. What's the difference?
Main differences are rate, onset, and termination. Non-paroxysmal, sometimes called accelerated junctional rhythm, starts and stops gradually. It's usually slower, rate maybe 70, 120 BPM, and often considered more benign, maybe lasting hours to days.
And what causes it?
Can be linked to things like heart attack, especially inferior, myocarditis, heart failure, COPD, low potassium, digitalis toxicity, certain drugs. P waves might be absent.
Okay, that's non-paroxysmal. What about paroxysmal?
Paroxysmal junctional tachycardia, also called junctional ectopic tachycardia or GET, is characterized by that sudden onset and abrupt stop. The rate is faster, typically 110, 250 BPM.
Wow, much faster.
Yeah, it's actually more common in children, rarer in adults. It can happen in normal hearts with congenital heart disease or after heart surgery. If it's incessant, again, it can lead to cardiomyopathy. Often you don't see P waves during the tachycardia itself.
Okay, so speed and suddenness are key differentiators. Let's move to another big one. Atrial flutter. Sounds very rapid.
It is. Atrial flutter is a rapid but organized reentrant arrhythmia within the atria, often kicked off by premature atrial beats.
What causes flutter? Similar things to other tachycardias.
Can be acute causes, like after surgery, especially chest surgery, pneumonia, myocardial ischemia, or chronic causes underlying heart or lung disease, hypertension, structural heart issues, and enlarged atria are common factors.
And the ECG, flutter has a classic look, doesn't it?
It does. The hallmark is regular, uniform flutter waves, which are essentially very fast P waves. They often have that distinctive sawtooth or picket fence appearance, especially clear leads 2, 3, and AVF.
Sawtooth waves. Got it.
These flutter waves are typically inverted in those inferior leads and often upright in V1. The baseline between them isn't flat. It's wavy or undulating. The atrial rate is super fast, usually around 300 BPM, give or take 50.
300. How does the heart handle that?
Well, the ventricles usually can't keep up. The AV node blocks some of those impulses, so you get different levels of AV block. Maybe 2.1 block is common, meaning an atrial rate of 300 gives a ventricular rate of 150. Could also be 3.1, 4.1, or even variable block.
So the ventricular rate depends on the AV block.
Exactly. And unlike some other SVTs, things like carotid massage or drugs like adenosine won't stop the flutter. They'll just increase the AV block temporarily, slowing the ventricular rate, which can actually make the sawtooth waves easier to see.
Useful trick. The notes categorize flutter. Typical counterclockwise, typical clockwise, and atypical. What's the difference electrically?
Typical counterclockwise is most common, maybe 90% of typical flutter. The impulse goes down the lateral right atrium wall and up the septum, gives those inverted sawtooth waves in inferior leads, and a specific biphasic look in V1, flat, then upright.
Okay. And clockwise?
Opposite direction. Down the septum, up the lateral wall. ECG shows broad, notched, upright flutter waves, followed by an inverted bit in inferior leads. V1 often shows a broad, notched negative wave, turning upright at V6.
And what's this cavotricuspid isthmus flutter?
The CTI is the critical piece of tissue in the right atrium, between the inferior vena cava and the tricuspid valve that's part of the circuit in typical flutter, whether it's counterclockwise or clockwise. Ablating that isthmus is the standard treatment for typical flutter.
Ah, so CTI flutter is typical flutter. What about non-CTI or atypical flutter then?
These are macro reentry circuits, usually in the right or left atrium, but they don't use the CTI. Often related to scars from previous surgeries, like AST repair, mitral valve surgery, or ablations, especially left atrial ones for AFib.
So scar tissue again.
Often. The ECG can be more varied, maybe lower amplitude P waves. Rate can range more widely, maybe 120, 300 BPM. A V1 morphology might give clues. Deeply inverted waves suggest right atrial origin. Upright waves suggest left atrial. There are various complex patterns, too.
The notes also mention distinguishing flutter with 2.1 block from atrial tachycardia with 2.1 block. Sounds tricky.
It can be. Key things pointing to flutter are the much faster atrial rate, usually 240, 250, often near 300, those inverted sawtooth waves in inferior leads, and the undulating baseline. Atrial tach usually has a slower atrial rate, maybe a 150, 250, often upright Ps in lead 2, and a flat baseline between Ps.
Good distinctions. And there's a note about digitalis toxicity.
Yeah, flutter with a slow ventricular rate and upright P waves with ST depression and lead 2 can sometimes be a sign of dig toxicity. Worth keeping in mind.
Definitely. Okay, last big one. Atrial fibrillation, AFib. Probably the most well-known arrhythmia.
Very common, yes. AFib is characterized by chaotic, disorganized electrical activity in the atria. Multiple independent wavelets firing off rapidly, usually over 350 BPM. Like flutter, often triggered by premature atrial beats from various spots, especially the pulmonary veins.
And the ECG in AFib, the classic sign is?
Irregular rhythm. The RR intervals are all over the place, completely unpredictable. You typically don't see organized P waves. Instead, you see fibrillatory waves or F waves.
Well, wavy bass.
Exactly. Could be coarse, bigger waves, 0.5 MV, or fine, smaller waves, 0.5 MV, or sometimes barely visible at all. But the key is that irregular ventricular rhythm.
AFib gets classified too, right? Paroxysmal, persistent.
Yep. Recurrent AF means 2 or more episodes. Paroxysmal AF stops on its own or with treatment, usually within 7 days, often less than 48 hours. Persistent AF lasts longer than 7 days. Permanent AF is when cardioversion hasn't worked or hasn't been tried, and you accept the AFib is there to stay. And lone AF is AFib in younger folks, 60, with no obvious heart or lung disease cause.
Can AFib be tricky to spot on the ECG sometimes? Can it mimic other things?
Occasionally, yeah. If the ventricular rate is very fast, it might look regular at first glance, maybe mimicking an SVT. But carotid massage can help slowing the AV node, often reveals the underlying irregular F waves. Also, coarse F waves can sometimes be mistaken for P waves, maybe confusing it with MET.
And notes mention Ashman phenomenon in AFib. What's that?
Ashman's. That happens because of the irregular rhythm. You get a long RR interval, followed by a short RR interval.
Long beat, then a quick bit.
Right. The long interval can make the right bundle branch take longer to recover, prolonged refractory period. So when that next beat comes quickly after the short interval, the right bundle might still be refractory.
Can't conduct properly.
Exactly. So that beat gets conducted aberrantly down the left bundle only, resulting in a wide QRS complex that looks like a right bundle branch block. It's important because it's still a supraventricular beat, just conducted weirdly, not a ventricular beat.
Good point. Not all wide beats in AFib are ventricular. Lastly, the notes stress AFib plus WPW syndrome is really dangerous. Why?
Extremely dangerous combination. Remember, WPW means there's that accessory pathway, the bypass tract.
An extra wire.
Right. In AFib, the atria are firing chaotically at 350 plus BPM. Normally, the AV node acts as a gatekeeper, limiting how many signals get to the ventricles. But the bypass tract doesn't have that filter.
So the ventricles get bombarded with rapid signals.
Exactly. Impulses race down both the AV node and the bypass tract uncontrollably. This can lead to an incredibly fast, chaotic ventricular rate, which can quickly degenerate into ventricular fibrillation VFib.
Which is life-threatening.
Absolutely. Can lead to sudden cardiac death if not treated immediately.
Scary stuff. What does the ECG look like in AFib with WPW?
You'll see the irregular RR intervals of AFib, but the ventricular rate is often extremely fast, maybe 120, 150 BPM or way higher. And the QRS complexes are typically wide and slurred due to that pre-excitation via the bypass tract. Those are the delta waves. The QRS width can vary beat to beat depending on how much conduction goes via the normal path versus the bypass path. Sometimes you get really bizarre fusion beats.
We have covered a ton of ground. The notes wrap up in the case study. An 11-year-old boy with palpitations. What were the highlights?
Right, 11-year-old, palpitations, heart rate 212 DPM, but blood pressure was okay. ECG showed retrograde Ps buried in the ST segment, a specific Rs complex in V1, short RB interval, narrow QRS but with some slurring, notching in certain leads, no normal septal Q waves.
And they gave adenosine.
Yep. Heart rate slowed to 125, where they became regular. Normal P waves appeared, but with a short PR interval, and some T wave inversions popped up in V1, V3.
And the diagnosis based on all that?
Antidromic AVRT using an atriofascicular pathway, a specific type of bypass tract, sometimes called Maham fibers. These pathways have characteristic features. Fast rate, 130 to 70, specific QRS axis, 0 to 75 degrees. QRS usually 0.15 sec, that's slurring notching. R-wave and Lin-Li, RS and V1.
Wow, that case really ties together a lot of the ECG clues we've been talking about.
Absolutely. It really shows how you need to look at everything. P waves, intervals, QRS shape, clinical picture, response to meds to figure out exactly what kind of tachycardia you're dealing with.
Well, we have certainly taken a deep, deep dive into narrow QRS tachycardias.
We really have. We went all the way from sinus tachycardia, POTS, IST, through all the SVTs, AVNRT, AVRT, the rarer SART IRs than the automatic ones like focal atrial, multifocal, junctional, and finishing with flutter and fibrillation, including that dangerous WPW combo. Quite the journey.
And it's just amazing, isn't it? They all share that fast rate and usually narrow QRS, but the underlying electrical reasons, the mechanisms, are so different.
Leading to all those different ECG patterns we discussed.
It really drives home how looking closely at those subtle ECG differences combined with the patient's story is just crucial for getting the diagnosis right and figuring out the best treatment.
Absolutely critical.
So for you, the learner, we really hope this deep dive has given you a much clearer framework for understanding these complex rhythms. It makes you think, doesn't it? Considering how intricate the heart's electrical system is. What other unexpected ways could things go wrong and cause weird rhythms? And what cool future tech might help us understand and treat them even better down the road?
Definitely food for thought. Plenty more to explore in the world of electrophysiology.